Hello everyone, welcome to my YouTube channel. Welcome to my presentation. Our topic is all about AP projection of pelvis. Pelvis AP projection. The bony landmarks used in radiography of the pelvis and hips are as follow. Iliac crest. We have the anterior superior iliac spine, pubic symphysis, greater trochanter of the femur, ischial tuberosity, tip of the coccyx. Most of these points are easily palpable, even in hypersthenic patients. However, because of the heavy muscle immediately above the iliac crest, care must be exercised in locating these structures to avoid centering errors. It is advisable to have the patient inhale deeply while the muscles are relaxed during expiration. The radiographer should palpate the highest point of the iliac crest, the highest point of the greater trochanter, which can be palpated immediately below the depression in the soft tissue of the lateral surface of the hip, is in the same horizontal plane at the midpoint of the hip joint and the coccyx. The most prominent point of the greater trochanter is in the same horizontal plane as the pubic symphysis. Whenever possible, scan of the chest should be acquired within a single breath hold, as this will prevent misregistrations that may cause uneven patient breathing between scan. Patient position. Place the patient on the table in the supine position. Center the mid-sagittal plane of the body to the midline of the grid and adjust it in a true supine position. Okay, note, do not attempt to rotate the legs if fractures involving hips are suspected. Image receptor we are using is 35 by 43 centimeter crosswise grid. Okay, the central ray is perpendicular to the midpoint of the image receptor. Unless contraindicated because of trauma or pathologic factor, medially rotate the feet and lower limbs about 15 to 20 degrees to place the femoral neck parallel with the plane of the image receptor. Medial rotation is easier for the patient to maintain if the knees are supported. The heels should be placed about 8 to 10 inches or 20 to 24 centimeter apart. Immobilize the legs with sandbags across the ankles if needed. Check the distance from the axis to the tabletop on each side to be sure that the pelvis is not rotated. Okay, this image is the AP pelvis with femoral necks and trochanters in correct position. Feet and lower limbs medially rotated 15 to 20 degrees. Correctly placed with the upper femora in correct profile. Okay, this image is the AP pelvis with femoral necks and trochanters poorly positioned because of the lateral rotation of the limbs. Feet and lower limbs in their natural laterally rotated tabletop position, causing poor profile of the proximal femora. Central ray. Center the IR midway between the axis and the pubic symphysis. The center of the IR will be about 2 inches or 5 centimeter inferior to the axis and 2 inches or 5 centimeters superior to the pubic symphysis in average size patient. Use gonadal shield if it doesn't compromise study. SID, we are using 42 to 44 inches or 102 to 113 centimeter. Collimation on 4 sides to include entire pelvis. Respiration, suspend during exposure. Okay, we have also a special projection taken for the congenital dislocation of the hip. Martz and Taylor recommended two AP projection of pelvis for demonstration of the relationship of the femoral head to acetabulum in patients with congenital dislocation of the hip. The first projection is obtained with the central ray directed perpendicular to the pubic symphysis to detect any lateral or superior displacement of the femoral head. The second projection is obtained with the central ray directed to the pubic symphysis at the cephalic angulation of 45 degrees. This angulation casts the shadow of an anteriorly displaced femoral head above the acetabulum and shadow of the posteriorly displaced head below that of the acetabulum. Okay, structure shown in AP projection of the pelvis. We have the iliac crest, ala of pelvis. We have the anterior superior iliac spine. We have the sacroiliac joint. We have the anterior inferior iliac spine. We have the femoral head, greater trochanter. We have the obturator foramen and the pubic symphysis and lesser trochanter. Okay, the AP projection of the pelvis should be demonstrated. Enter pelvis along with the proximal femoral, lesser trochanter, if seen, demonstrated on the medial border of the femora. Femoral neck in their full extent without superimposition, greater trochanter in propel, both ilia equidistant to edge of radiograph, both greater trochanters equidistant to the edge of the radiograph, lower vertebral column centered to the medial of the radiograph, symmetric obturator foramina, usual spines equally demonstrated, symmetric ilia, sacrum and coccyx aligned with the pubic symphysis. Okay, that's all for today. I hope you gained some knowledge in this video. Hope you like it. Please like and subscribe for more updates and topic. Thank you for watching.